Hello, this is a talk about the update on type 2 diabetes in 2025. And I'm starting with a slide on the disclosures of the CME Planning Committee. Um, and I am Dr. Mariam Manoukian. I grew up in Armenia and went to medical school in Yerevan, subsequently did my PhD and endocrine fellowship in Russia, and then moved to United States and did my internal medicine training and board certification in United States. I practice currently at El Camino Health, and my practices mostly includes metabolic diseases, diabetes, obesity, thyroid, and other medical conditions. This is a slide on fast facts on diabetes. The statistics is about the last time they were done in 2023, and we know that there is diabetes is growing condition. It's about 11.6% of US population currently is diagnosed with diabetes or pre-diabetes, and 29%, including 29, most of them are adults and most of them have type 2 diabetes. A lot of people are undiagnosed, and this is a very important population that we need to address. Total of 97.6 million of US population has pre-diabetes, which is exactly what we as physicians need to know and talk about. This is a slide about age-adjusted and country prevalence of diabetes among patients who are ages 20 and older, a comparison between 2004 and 2021. And, the darker the color, the higher is the percentage. And you can see that if in majority of the country, the percentage of diabetes was between 4 and 9%, then now the majority of the country has prevalence of diabetes above 11%, particularly in the Southwest. When we look at the similar map of obesity, you can see that the map in United States of obesity, overweight, and obesity mirrors the percentages of diabetes. This is an interesting slide that I came up myself when I put together the map of obesity and the fast food density. So you can see that that also mirrors in United States. The more fast food places they are, higher is the percentage of diabetes. I'd like to show this slide about Dr. Max Pemberton, who is a famous kind of these days they're called influencers, but a famous physician writer who in 2016 said, I'd rather have HIV than diabetes. Pretty shocking statement. And he explained it that diabetes is not just an irritant, it's a serious condition. And many people die from heart attacks and strokes, and the life expectancy is definitely decreased in patients with type 2 diabetes. Now, why is diabetes bad? What's wrong with having diabetes? Like certainly what Mark Pemberton already said, is not just a high sugar. Frequently, people walk around with elevated sugars, and it doesn't bother them. It's not like every diabetic is going to have the classic symptoms of dry mouth or running to the bathroom or having blindness from the get-go. It's the years of having diabetes is eventually brings to devastating complications, and certainly a lot of hospital admissions. They were almost 8 million hospital admissions and discharges in United States in 2020 in patients with diabetes. They were it's a major cause of cardiovascular disease, They were 368,000 heart attacks per year that were contributed to diabetes, and more than 300,000 strokes. It's also biggest cause of lower extremity amputations. Less and less, however, still a cause for hyperglycemic crises, and more than 51,000 cases of hypoglycemias, which frequently in before the contemporary treatments and before the advances in diabetology were kind of a major cause of death in diabetics. Diabetes remains the major cause of kidney disease, of kidney failure, dialysis, and kidney transplants, uh, visual disability, and blindness. And also diabetes is the seventh cause of death in United States and many other countries. It's kind of a in the kind of a higher levels of causes of mortality. It is also an extremely expensive disease because of the complications and, like I mentioned, dialysis, amputations, disability, hospital admissions. So it is an expensive disease to have. What are the risk factors? Certainly, I already showed the slides of correlation with obesity. Certainly, the overweight and obesity is number one uh, cause and predecessor of diabetes. Interesting enough, physical inactivity independently of weight can be contributing to diabetes. The A1C, the higher the A1C, the higher the level of complications. The complications are directly related to as causes of complications. The high blood pressure, which is a part of diabetes. It's not just the high sugar, but it's also elevated blood pressure that is a part of metabolic syndrome and diabetes. And until, even though it's known, it's still, we are not doing great with its control. High cholesterol, a typical cholesterol of high triglycerides and low HDL, are all of these are contributing to diabetes. So when we talk about complications, it's not just the high blood sugar that causes complications of diabetes. It's also the high blood pressure and cholesterol. All of these certainly need to be treated. What is the pathogenesis of type 2 diabetes? I like this slide because it also kind of shows the progression in our knowledge of diabetes. When I was in medical school, the diabetes was a disease of pancreas, just pancreas with, it was a disease when people could not make enough insulin. With time, however, we found out that it's not just the pancreas that is involved, it's also the liver and the fat tissue. It was called a triumvirate. And subsequently, we found out that there are not just those three, but there is also the kidneys, an endocrine organ that is involved. So is the muscle, the gut, which is certainly the production of the GLP-1s, the incretin hormones, and also the brain. All this contribute to progression of diabetes. And having this slide is also is easy to see how the pharmaceutical industry actually attacked the defects in a sense, or the players in the players of type 2 diabetes. The concept of diabesity came out, and insulin resistance and diabesity, how we start with one condition and it kind of turns into a diabetes and diabetic complications. And certainly it develops more and more with gut microbiome being a part of it, inflammatory markers, and certain neurotransmitters. I like this slide also that shows the progression from prediabetes, from actually normal metabolic condition into prediabetes, and subsequently into diabetes. And it's a years and years. If you look at the blue slide on top, it shows that how for years between 0 and -10, people develop insulin resistance. And the cause of this is certainly unhealthy food. If the person is eating the high sugar, high processed food for many years, they slowly develop insulin resistance. And at some point, the body is unable to control that insulin resistance, insulin deficiency develops, and the sugar starts going up in the bloodstream. That is when we diagnose people. But for years and years prior to that, people have this insulin resistance that is, or which we called as a metabolic syndrome or prediabetes, that the cardiovascular disease already starts. So the patient does not even have to develop diabetes in order to already develop coronary artery disease, atherosclerosis, heart attacks, and etc. How do we approach treatment of in general, not just the treatment, but also how do we approach patients with diabetes? By many factors. We used to say that A1C of 6.5 should be in every patient. With time, we certainly realize that not every patient needs to have an A1C of 6.5 or below. Once they are diagnosed with diabetes, it depends on many factors. It's their life expectancy, their complications. And actually, my next slide is kind of has it in a kind of a funny diagram that shows that if the person is bedridden and is at the end of his life, there's actually doesn't matter what their A1C is, because the main goal of having controlled A1C is to control complications. If the person is older and has complex health issues, then maybe 8% is not bad. If the person is kind of relatively healthier and is able to walk, then we want to shoot for less than 7.5%. For most adults, we want to have the A1C of less than 7. And people who are in good health and they have certainly younger people, they should have less than 6.5, and I would say less than 6. So the going from healthy person to this is kind of a throughout their lifespan, but even sometimes in a younger person who has a lot more complications, and we don't have to push the A1C too low. So first of all, in what is our goal in treating diabetes? It's certainly first and foremost we have to establish our goal, and the goal will depend on how much this person is where in their life, how many complications they have, what is their social determinants of health, their cardiovascular comorbidities. Certainly, we need to see these patients on a regular basis, encourage healthy lifestyles, reevaluate medication taking behaviors, overcome physician inertia. Physician inertia is certainly a big factor. Sometimes we get tired of non-compliant patients, and that is something for the doctors to overcome. But also, if the patient is not able to obtain the medicines, not compliant, then the goals would be different. So this is a slide from ADA that shows our main goal being reduction of diabetes complications, certainly, as I said, and how do we do that? And the number one thing is certainly the glycemic management, the blood pressure management, the lipid management, and how we need to use medications that will benefit the cardiovascular and kidney disease. This slide basically shows what is diabetes and how we need to control. And certainly the basis to all of this is the lifestyle management, diabetes education. So, and this brings me to the novel technology that we have. Again, when I was starting my career as an endocrinologist, we were checking blood sugars from the veins. Then it was like a major advance when we first time saw the fingerstick blood sugar monitors, and that was an incredibly benefit, and they changed the whole face of diabetology. And of course, within the last 10, 15 years now, we have continuous glucose monitors, which are not only they reduce the glycemic, the hyper and hypoglycemia and glucose variability, they teach us what is where the patients are in the good range, where the longer the patient is in good range, the higher is their chances of having no complications, and they potentially save money to improve not only diabetes management and fewer events and hospitalizations and etc. I like this quote from Thomas Jefferson saying, wisdom is knowing what to do next. And skill is knowing how to do it, virtue is doing it. Certainly, we can do the first part for patients, that is the CGMs, education is the skill, and then it's left to the patient what they are going to do it or not. So, a lot of patients refuse advances. So um, we have a variety of continuous glucose monitors these days. They are the intermittently scanned CGMs. Practically, I don't have any more patients on this. I would think the more modern ones that we have on the market are called real-time. Patients do not need to scan their device. They can constantly see their blood sugar on their monitor, little monitors, or on their phones or on their iWatches or on their watches. And there are several of them. The Dexcom 7, that is 10-day monitor, Libre 3, that is 15 days. iPro 2 Medtronic, it's usually connected to the Guardian pump. Eversense, which is CGM that is under the skin. It's put under the skin and shows blood sugars for 180 days. IQCheck Smart Guide, that is an alternative only in Europe. And we have two over-the-counter variations that do not require any prescriptions. These are Stelo, that is made by Dexcom, and Lingo, that is made by Libre. They are kind of more recommended for people who do not have diabetes, and they are the Lingo, for instance, the blood sugars do not go up above, I think, 200 or 220. So these are for people who do not really have diabetes. The something that we need to know, and probably kind of a good idea to remember, is that some of these monitors, sometimes the very important is the accuracy in whatever you can do to make sure that people do not do know this when you are when you are um, when you have the patients on continuous glucose monitors, it's that acetaminophen in high dosages can interfere with Dexcoms. In any dosage, it can interfere with Medtronic. Vitamin C certainly interferes with the Freestyle Libre products. Higher dosages more than lower dosages. Hydroxyurea, rarely. Some patients take it who have certain conditions, but they also interfere. And mannitol and sorbitol, these are for the Eversense that, I rarely use those. This is a data that you can see and discuss this with patients. I love this. It's kind of shows us the whole picture of where the patient was throughout the day, his blood sugars were throughout the day, and certainly it gives us a very good guidebook how to change. You can see that this particular patient particularly has elevated sugars, in the morning and after dinner, and how to manage this, and something that we call glucose in target, or also known as glucose management indicator, GMI. In this particular patient, it's 7.5. That those numbers usually correlate with their A1C. Even with the blood sugar of 44, I think this patient actually has very high level of hypoglycemia. There is a lot of things that need to be checked in and corrected in this particular patient. Very good, important information that there is significant A1C reduction by 1%. I can tell you that many medications that we use in diabetology don't give 1% A1C reduction just from using the CGM. This is a study, 24 weeks, the patient's A1C improved by 1%. I think in many of my patients, it can be even more, because when people know what's going on with them, they behave, they exercise more, they eat healthier foods, and they are knowledgeable to know that I should not be doing this or that because my blood sugar is going to go completely out of control. The problem with these medications is certainly the coverage. It's very well covered for patients on type 1 diet with type 1 diabetes. Not so much with the patients with type 2s, only on those people who are on insulin, and the ones who are not on insulin, they are with a history of hypoglycemia, which these days most patients are not on those medications. So it's kind of very hard to control, but Medicare has their requirements. And if you know the specific companies who can do that, they get your chart notes. If you say that the patient was seen in the office at least every 6 months, that they are following their diet, that they are doing everything, they are having occasional low sugars, you can do it. Certainly very important. We're going to talk a little bit about medication and diet and health, but the reason I kept this old slide from 2012, now I hope it's not the same numbers right now, that 1/3 of the doctors do not talk about weight. That's not part of their daily talks with the patients. Some data from the ADA 2025. This is many changes have been done. I always admire that every year they come up with new guidelines, and most of them are very similar to the year before, but some of them are newer, and the guidelines about the nutrition and exercise are kind of more developed, and the nutrition is promoting the healthful eating patterns, emphasizing a variety of nutrient-dense foods. I like that in this year's 2025 year, the ADA guidelines, there were 20 pages on nutritional guidelines, whereas 20 years ago, they were 4 lines. So now finally we realize that diabetes is a disease that depends on nutrition, and a lot of attention is paid to that. This data is extremely important. Medical nutrition therapy is associated with a reduction of A1C from 1 to 1.9, almost 2%. This is very big. When the patients realize, I frequently tell my patients that in 90% of patients with diabetes, it is a man-made disease because it depends on what the person ate or is eating. The couple of the lines I put from the guidelines from ADA guidelines for type 2 diabetics, certainly, we've been through a pyramid, then a plate. Now this is a new type of recommendation that kind of make more sense, that low carb patterns, eating to reduce A1C, and the focus on high quality, minimally processed, high fiber, nutrient dense carbohydrates, and the protein kind of amount has been rising, and it's now 0.8 to 1.5 kilogram per body weight, 15 to 20% of total calories. And it's kind of a not completely clear, inconclusive is how it's going to affect the cardiovascular risk. Fats have been pretty clear in this kind of as a recommendation. It's that fats consumed should be decreased amount of animal fat and saturated fat. This has been going on for a long time, mostly recommended olive oil and avocado oil. And also that first time they actually mentioned that Mediterranean eating pattern can improve both glycemic management and blood lipids. So it is kind of, they mentioned the Mediterranean diet. I'm a big proponent of intermittent fasting, as in there is multiple books that are written by Dr. Jason Fung about intermittent fasting, about its effect on diabetes, and they, and obesity particularly, but their first time ever, they put this slide and they kind of compare to religious fasting, which, you know, I do not agree, because intermittent fasting is I think totally different, and it's not, you know, as restrictive and as hypnotizing as religious fasting, but kind of they mentioned that it is a flexible duration and timing, varying levels of motivation. Hyperglycemia is and likely as motive is health related, and there is no added risk of dehydration. So basically the intermittent fasting is in that sense better, but there is no truly hypoglycemia risk in intermittent fasting unless the patient is on insulin. These are slides. This is a slide that shows how many diabetic medications we have. It's a very little you know, kind of a view. It's hard to read. I'm not going to delve into that because we're going to talk about this medication separately. Certainly, the medications now are classified. This is kind of a bigger slide showing the features of medications that we use and how are they related to glucose lowering level, to how much hypoglycemia they cause, their weight effects, their effects on major cardiovascular events, heart disease, kidney disease, and their side effects. This is kind of a very useful for having for medications that you want to know. And the big medications are those basically GLP-1s and dual GLP-GIP and DPP-4s, pioglitazone, sulfonylurea, and insulin. This is from 2025 Diabetes Care. I say treating diabetes is like a chess. This has been on my slides for as many years I've given talks on diabetes, but kind of this our chess has gone very interesting, because suddenly the GLP-1s that we are now commonly using have kind of overtaken the chessboard in a sense. So a lot of these other players are off the board, and when insulin was an extremely important player for many years, it's now practically is not used. So obesity management is a very important management in type 2 diabetes, because if you treat the obesity, you might actually never need to deal with diabetes. And medications that we're using should be improving the weight. So even modest weight loss improves glycemia and can reduce the need for medications. Weight loss improves A1C, and the metabolic surgery is the gastric bypass. We know that gastric bypass has been done for many years, and people who lost dramatic weight loss more than 20% or 20% usually cured the diabetes or led to a remission of diabetes, improved quality of life, improved cardiovascular outcomes, and mortality. All these studies have been done for many years. This is now we are getting the same results with medications as we used to get only from surgeries. So if we look at the different medication effect on weight, you can see that certainly metformin, as a person who probably wrote thousands and thousands of prescriptions for metformin, I would say it's close to zero, usually weight neutral medication. Alpha glucosidase inhibitors, certainly also are not big medications. You can see it when this slide was written in 2001, there is no GLP-1 and GIP analog combination drug. So you can see that GLP-1 analog here is written only 11%, and SGLT2s are able to be very small amount of weight loss. DPP-4s are also weight neutral. I would like to present you a case study from my own practice that certainly this is the, kind of a extreme of, we don't see too much of this kind of a extreme effect, but to show you how much medication can change a person's life. So patient started seeing me about 2, 3 years ago, just when the tirzepatide or Mounjaro just came on the market. So it's a 58-year-old woman with a long history of asthma and prednisone. When she saw me, she wasn't on prednisone anymore, but that made her gain 60 pounds. And she had diabetes for 10 years. She sedentary life, and she was a counselor at a local university. On her first visit, when she saw me in September 22, she is using a walker and a wheelchair. Her daughter is with her with a wheelchair. Her weight was 274 with a height of 5 feet, and the BMI was 53, blood pressure 153/93. She was on glargine of 50 units and a sliding scale insulin with it, and her finger stick in my office was 258 and A1C was 10.7. So I started her on tirzepatide, which is Mounjaro, on weekly, and started to taper her of glargine and aspart, and placed a CGM at the time, CGM 6 on her. So 3 months later, she kind of walked into the office. No, this is not 3 months. 2 years later, she walked into the office without a cane. Her weight was 165. She lost 110 pounds, 40% of her weight. Her height still remains 51. Her body mass index is still 31, and blood pressure normal. Her Dexcom now she's on 7, shows A1C of 5.3, and the only medication she's targeting range 95%. Her only medication at the time is already tirzepatide. I increased her tirzepatide to 10. She is also taking atorvastatin and lisinopril. She asked to increase the dosage. So we kept increasing the dosage, and her last A1C 5.2%, her weight 155. She's walking no problem. She's using a rowing machine 4 times a weekly and getting on and off a chair absolutely without any help. So such a dramatic change. This medication changed this patient's life. She could not believe, her family could not believe how she turned from this chronically ill woman into this person who is exercising now, walking. She just is a regular person now. So what are these magical drugs? The glucagon-like protein and gastric insulin polypeptide, or gastric inhibitory peptide. These are they're called glucagon-like protein 1 analogs. They are produced in the gut. These are incretin hormones, they're called. They're produced in the gut, and they uh, are usually their major effect is on certainly insulin and glucagon. They regulate those two. They make insulin produce when it's needed, which is called a glucose dependent. That is why these medications do not cause hypoglycemia, because if the patient takes the medicine and their sugar, they're not eating, their glucose is not going to drop, because they're not going to produce insulin blindly like many other medications we have on the market, or um, so hence they are not causing hypoglycemia. They decrease the gastric emptying. They have an impact on the heart. They are cardioprotective. They cause bone resorption. We need to know about that. They talk to the brain. This is an incredible effect through the neurotransmitters. They decrease the interest in food. They get rid of the food noise. This is a extremely effective for people who cannot function because they constantly want to eat. They affect the kidney and they improve the cholesterol. The GLP-1 and GIP analogs, these two medications can be used in monotherapy. They can be combined with other medications. Frequently, there is no need. They create obviously major weight loss. They have their cardiovascular benefit. They are low hypoglycemic risk. Their kidney benefits are phenomenal, and they create improve the fatty liver. So no wonder when this is a chart that shows how these medications came out. If those of you remember the older ones, like Byetta was the very first GLP-1 that showed up, and then came the Victoza, which was very popular. But you can see how their prescriptions are coming down. And then Trulicity was the Eli Lilly drug. This doesn't show this, just here we go. The Mounjaro came out in 2022 and spiked. Now, of course, it's very high. And certainly this is the Ozempic. You can see that the medication went from 50K prescriptions to 150K. Novo Nordisk became biggest moneymaker in Europe. This shows semaglutide in patients with heart failure. It improves the heart function. These medications are the comparison of the two drugs definitely shows that tirzepatide or Mounjaro is more potent than semaglutide. The Surpass 2 study showed that the weight in kilograms for semaglutide is minus 5 kilos versus the high dose of the tirzepatide. Now, it would have been kind of a more fair to have a 2.4 here, because if we're comparing weight loss, we need to compare apples to apples. But in any case, we see in practice that tirzepatide is more potent. You can see that tirzepatide has a much bigger weight loss. It also has better A1C improvement. So many new drugs are on the market. There are many of them. They are for Glipron, another Eli Lilly drug, just about to come on the market. And it's going to be, this is the first one going to show up on the market. It's going to come out in sometimes at the end of the year, a big weight loss drug. The oral Wegovy is going to come out on the market, 13% weight loss. It's kind of hard to understand why the oral semaglutide, we have Rybelsus right now, that doesn't cause weight loss as much. So they know what they're doing. And certainly many other companies are having drugs there is retatrutide that is going to cause 24% weight loss, another Eli Lilly drug. So some things that from my own practice that I would say, and also that are, so these are these medications are brilliant. However, what the companies show and what we see in practice are sometimes different. So patients lose weight. It doesn't matter what their BMI is. And there are some non-responders, about 14% in men, 41% in men. This is in one Greek study, and higher non-responders are the ones on SSRI. So now, do I have patients who do great on SSRIs? Yes. What do I tell my patients? This is, I call Dr. Mariam's um, list, my short list for people who are going on it. First of all, they're powerful drugs for diabetes and weight loss, improving overall health, but they need to be used thoughtfully and with the right expectations. Tolerability, 5% will never tolerate it. Weight loss expectation, many people will lose large amounts of weight. A small number particularly with severe obesity loses much less weight. Common side effects are nausea, constipation, less abdominal pain, and diarrhea. Hair loss may occur in some people, usually improves in 6 months. Ozempic face is a known fact. People get hollow cheeks and more wrinkles. Obviously, weight loss will cause these things. And, the certainly the plastic surgeons are benefiting from it. How to eat while on GLP-1s is very important. Eat small meals, high in fiber, low in fat. Avoid fast food, highly processed meals. Drink plenty of water, but not with food. Eat lean proteins. Exercise is critical. If the patients do not exercise, a lot of particularly older people, they're not used to exercising. There is a new concept that is called sarco-obesity. People, even though they are obese, they're still overweight, but now they're sarcopenic. Uh, they lose a lot more muscle. Now imagine if for every 3 pounds they lose 1 pound of muscle, then for 30 pounds they lose 10 pounds of muscle. For exercises, this number is a lot better. So they can actually lose only 3 pounds of muscle. So people need to know this. You got to drill this into the people. You are not going just to lose weight. And for that, it's not just the walking. People would say, oh, I'm walking my dog. That is not going to work. You got to tell them they need to do resistance training in order to keep the muscles, be it band training, be it weight training, at least 60 minutes a week, in addition to 150, etc., etc. Health benefits are incredible. They are beyond diabetes and weight loss. They help to protect the heart, brain, kidneys. Now we have new studies. They are thinking of putting them into uh, that Alzheimer's disease might be prevented. Kidneys last longer. Fatty liver disease we have now indication for fatty liver disease. Sleep apnea improves and also appear to be modestly reducing risk of 14 types of cancer. Safety concerns. First and for most, we have a black box that says that there is increased thyroid cancer. Be careful. That is absolutely nonsense because, patients, the thyroid cancer that people need to be concerned. Now, the cancer is only shown in rodents, never in humans, but it's a C cell calcitonin secreting or medullary thyroid cancers. These cancers are in people with MEN2. I've been an endocrinologist for now 40 years, I'm sorry to say, and I have seen 2 cases of MEN, so very rare. So there is no evidence of thyroid cancer. Pancreatitis, on the other hand, is increased, but it's like in 1,000 people, there is one patient, then normally 2, 3 in 1,000 people. So what are the breakthroughs? CGM easier access, GLP-1, GIP are helping to improve management, and we need certainly more cutting edge innovation. I would say we need these things to become more available. That would be the most important thing. And now going back to Dr. Pemberton's saying that I rather have diabetes, I think that CGMs, insulin delivery systems, telehealth, GLP-1, dual agonist, SGLT2, if available to patients, and diabetes may be conquered. And with that, I want to thank you and demonstrate to you how much Mount Ararat looks like Golden Gate Bridge. Thank you.